Management of a patient with septic shock. Septic shock is a severe, life-threatening condition characterized by hypotension and tissue hypoperfusion despite adequate fluid resuscitation, often resulting from a systemic infection. It requires prompt and systematic management to optimize outcomes. Below is a detailed outline. 1. Initial assessment and diagnosis. Rapid recognition. Signs include fever, tachycardia, tachypnea, hypotension, altered mental status, and decreased urine output. Diagnostic criteria include persistent hypotension requiring vasopressors to maintain a mean arterial pressure, MPAT 65 mm/Hg, and lactate Tate 2 mmol despite adequate fluid resuscitation. History and physical examination. Identify potential sources of infection, e.g. pneumonia, urinary tract infection, wound infections. Assess for risk factors like recent surgery, immunosuppression, or chronic illnesses. Investigations, blood cultures, at least 2 sets before starting antibiotics. Other cultures, urine, sputum, wound, or invasive device sites. Blood tests, lactate, complete blood count, renal function, liver enzymes, coagulation profile. Imaging, X-rays, CT, or ultrasound to identify the source of infection. 2. Immediate management, first hour. A. Sepsis resuscitation, sepsis bundle. Airway and breathing. Ensure airway patency. Provide oxygen to maintain SpO2 92%. Intubation and mechanical ventilation if respiratory failure occurs. 2. Circulation. Fluid resuscitation. Administer 30 milliliters per kilograms of isotonic crystalloid solution, e.g. normal saline or Ringer's lactate, within the first 3 hours. Monitor for fluid responsiveness using dynamic measures, e.g. stroke volume variation, passive leg raise. Vasopressors. Initiate norepinephrine if MAP remains 65 mmHg after fluid resuscitation. Add vasopressin or epinephrine if needed to maintain MAP. Dobutamine for persistent hypoperfusion despite adequate MAP. 3. Antibiotic therapy. Administer broad-spectrum antibiotics within the first hour, e.g. piperacillin tazobactam plus vancomycin. Adjust therapy based on culture results. 4. Lactate monitoring. Measure lactate levels and recheck every 2 to 4 hours to guide resuscitation. 3. Source control. Surgical intervention. Drain abscesses, debride infected tissue, or remove infected devices, e.g. catheters. Percutaneous drainage. Consider for localized collections, e.g. empyema or abscess. Stop ongoing infections. Remove potential sources like infected central lines, Foley catheters, or prosthetic devices. 4. Ongoing management. A. Hemodynamic support. Fluid management. Assess fluid responsiveness with frequent reassessment. Avoid over-resuscitation to prevent fluid overload. Vasopressors and inotropes. Continue and titrate based on MAP and perfusion markers. B. Monitoring. Vital signs. Continuous monitoring of heart rate, blood pressure, respiratory rate, and SpO2. Organ function. Monitor urine output, target 0.5 milliliters per kilo-R, liver enzymes, and coagulation profile. Central venous pressure, CV. Consider for advanced hemodynamic monitoring. Arterial blood gases. To assess oxygenation and metabolic status. C. Adjunctive therapies. Corticosteroids. Low-dose hydrocortisone, 200 milligrams per day for refractory shock. Glucose control. Maintain blood glucose levels between 140 to 180 milligrams per liter with insulin therapy if needed. Nutrition. Start early enteral nutrition. Avoid total parenteral nutrition unless absolutely necessary. 5. Supportive care. Mechanical ventilation. Use lung protective strategies, low tidal volume, PEEP, renal replacement therapy, RRT, for acute kidney injury with volume overload or electrolyte imbalances. Sedation and analgesia. Use minimal sedation protocols to facilitate recovery. Prophylaxis, deep vein thrombosis, DVT, prophylaxis with low molecular weight heparin. Stress ulcer prophylaxis with proton pump inhibitors. 6. Long-term management. Rehabilitation. Address post-intensive care syndrome with physical and psychological support. Follow-up. Assess for recovery of organ function and evaluate the need for further interventions. Chronic infection management. Treat lingering infections or address any complications. 7. Prognosis and goals of care. Frequent reassessment. Adjust interventions based on clinical response and organ function. Discuss goals of care. Engage patients and families in decisions about invasive treatments, especially in advanced or irreversible organ failure. Timely and coordinated care, guided by protocols like the Surviving Sepsis campaign, is essential for improving survival and outcomes in septic shock.